This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 4, Errors in Automaticity. Key concepts. Upon completion of this chapter, you will understand these concepts: automaticity as an etiology of dysrhythmia, the ability to identify, given an EKG strip, either in lead 2 or MCL1, dysrhythmias caused by a change in automaticity, and then treatments for dysrhythmia is caused by an error of automaticity. Let me just add one more concept on this. Most of us have the ability to generate or look at a 12 lead at this point. Rather than just using lead 2 or MCL1, it is suggested that if there's any error, if the heart rate is too slow or the heart rate is too fast, or there's any cardiac dysrhythmia disturbance that is seen, that you probably should run a 12 lead. So this is chart or table 4.1, charts of dysrhythmias by origin. And we can have things that are slow or things that are fast, which is bradydysrhythmias or tachydysrhythmias. And as far as the slow stuff, SA nodal blocks, AV blocks, or bundle branch blocks can all generate a slow conduction pathway. Reentry or short RP intervals, things like A flutter, AV nodal reentrant tachycardia, and this would be things like reentry tachycardias, and we'll talk about those. Wolff-Parkinson-White's one of those. AV reentrant tachycardia, ventricular tachycardia. So the ventricles themselves have decided to make a new pacemaker site. It's pretty simple. In ACLS, and this will be the treatment algorithms that you need to view, if it's too slow and we think that there's cardiac compromise, we speed it up. If it's too fast, we slow it down. And there's several methods to do that. So abnormalities in automaticity over here. Decreased automaticity would be things like sinus bradycardia or wandering atrial pacemaker. Increased abnormality, automaticity, or long RP interval, sinus tachycardia, atrial fibrillation, focal atrial tachycardia, which would mean it would come from one spot. We'll talk about these here a little bit as we go through them. Accelerated junctional tachycardia, multifocal atrial tachycardia, and junctional ectopic tachycardia. So, chief concerns. We generally find a patient that's in hemodynamic compromise, so they're weakness, they have dizziness, and those symptoms we can get those symptoms from a variety of disorders. Dysrhythmias can decrease cardiac output, can alter the heart's hemodynamics or its ability to eject blood, and may lead to faster or slower heart rates. So it's kind of a self-perpetuating circle once they get into this. An example of this is, let's say that they were in a tachycardic rhythm, and they were so fast that they weren't perfusing their heart enough. Well, eventually they could go to a bradycardic rhythm or go into full arrest. Normal automaticity. Now, normal automaticity is our normal pathways: sinoatrial node, the primary pacemaker side of the heart, and the atrioventricular node, latent or backup pacemaker. Dominance. Sinus node has the fastest automaticity, and the rate of depolarization controls the heart rate and rhythm. And we're going to kind of just go do a quick review on this. So as we look at the heart, we have essentially 3 pacemaker sites. This is from a basic EKG. We have the SA node, the AV node, and then down here in the ventricular muscle, we have the Purkinje, or ventricular muscle itself. Now, each one of these has an intrinsic rate. 60 to 100 for the SA, 40 to 60 for the AV, and then the ventricular area has 20 to 40. Now, this is normal automaticity or normal pace setting, if you will, for those sections of myocardium. So what we're talking about here under normal automaticity is this fires, spreads across the atria contract, ejecting blood into the ventricles. The stimulation wave hits the AV node and the timing's just about right to where it fires off an electrical stimulation as well. Now, the impulse gets down here to the Purkinje system and causes a contraction in the ventricles that is in this direction. Now, either this goes into the lungs to get perfused with oxygen, or it goes out to the body through the aorta to perfuse the body. That all happens 60 to 100 times a minute in the normal setting. Errors in automaticity. So these are all kinds of things that can pop its ugly head up and give us problems. So increased automaticity, narrow QRS. So this would be talking about the QRS complex, and that it is narrow, which means that it is less than 0.12 in duration. Things like sinus tachycardia, focal atrial tachycardia, and we'll kind of... A focal atrial tachycardia would be... I have the SA node firing, but I might have another little section here that's irritable and wants to fire as well. Well, both of these are giving their signals to the AV node. Sinus tachycardia would just be a sinus-originated beat greater than 100 beats per minute. Accelerated junctional rhythm. Now we're talking about this guy right here, or the AV node. The junction has an intrinsic rate of 40 to 60 beats per minute. Well, what if you had no P waves and you thought, or the P waves were inverted, and you thought that the junction was now taking over as a primary pacemaker site? Well, if it was an accelerated junctional rhythm, very simply it would be greater than 60 beats per minute. Junctional escape tachycardia, which would be still run from the junction, but since it's tachycardic, greater than 100 beats per minute. Irregular rhythms, multifocal atrial tachycardia, which goes back to our first thing up here. I'm going to clear this off so we can kind of see here a little bit. Redraw a heart. SA nodes here. So multifocal atrial tachycardia would be multiple focal points in the atria that is now all firing at the AV node, which now is trying to receive all this information. Atrial fibrillation, for whatever reason, the atria are now fibrillating. So all the F waves that have a strong enough amplitude now hit the AV node and cause it to fire. QRS complexes, wide QRS complexes, regular rhythm, accelerated ventricular rhythm, which would be the normal intrinsic rate of the ventricles, is 20 to 40. So if you had a wide complex QRS that was greater than 0.12, it's suggested at that point that it's ventricular in origin. And if the actual beats were greater than, let's say 40 beats per minute, let's say that they were 66, then that would be an accelerated ventricular rhythm. Ectopic beats, which are just premature beats. Supraventricular ectopic beats would be things like PAC, or a premature atrial complex. They look like a normal beat, only the normal beat becomes out of rhythm, and the P wave has different morphology. Premature junctional complex would be the same thing, only from the AV node. So it would be a premature, the beat that would form in there wouldn't have no P wave. Ventricular ectopic beats, which are PVCs, premature ventricular complexes. The PVCs are wide and aberrant QRSs, greater than 0.12. And they also have some terminage that can go with this, bigeminy, trigeminy, and so on. Couplets, we'll talk about those here a little bit later. So we worry about ventricular ectopic beats as well, especially if they're perfused or not. Decreased automaticity, narrow QRS complex, regular rhythm. We can either have a sinus pause, a sinus node just says, I'm going to set this one out, or sinus bradycardia, which would be a sinus-originated beat less than 60 beats per minute. Now, if you're having problems identifying these, please look back through the basic EKG lectures and the sections and be sure that you can identify these rhythms. Accelerated automaticity. We're going to talk about these kind of in section here. So, key concepts. Ischemia-induced increased automaticity. So, the heart becomes hypoxic, and now the heart rate increases because it feels the hypoxia. It sends off the trigger, I need more blood supply. The easiest way to do that is to dump a little catecholamine. They're regular. They're narrow complex tachycardia. This can include sinus tachycardia, which would be from the SA node, focal atrial tachycardia, which could be from one point in the atria, wandering atrial pacemaker, which identifying wandering atrial pacemaker is more than 3 P waves that are different in the same 6-second strip. An accelerated junctional rhythm, which would be a junctional originated beat, no P waves or inverted P waves, that is greater than 60 beats per minute. And then a junctional ectopic tachycardia, which would be no P waves or inverted P waves greater than 100 beats per minute. Accelerated automaticity continued. Additional concepts: irregular narrow complex rhythms, multifocal atrial tachycardia. The reason that it's like that is because multifocal atrial tachycardia is coming from multiple locations. Atrial fibrillation is another one, and that's because the atrias are fibrillating. Digitalis toxicity can sure get us there. Dig does two things. It increases contractile force strength, but it slows conduction through the AV node. If the heart's giving off hypoxia, or we've increased our amount of digitalis and become toxic, very simply, those two combinations of increasing contractile force strength and reducing conduction velocity could generate an aberrant or an ectopic rhythm. Regular wide complex tachycardias, accelerated idioventricular rhythms. This would be something that looks similar to VTAC, but was greater than 40 beats per minute. So we start worrying about ventricular-based tachycardias. Definitely we start worrying about them if they're over 100, but we generally only treat them if they're over 150. That's per AHA standards. We watch them maintain and monitor from 100 to 150. They get over 150 and we have cardiac symptoms. We need to pull the trigger on the treatment. Ectopy. Key terms. Autorhythmicity. Now, what that means is the ability to spontaneously depolarize in a rhythmic fashion. Ectopic focus. Area of irritability that causes an abnormal spontaneous depolarization. Coupling interval. Relationship of premature complexes to the preceding complex. So, if I had one complex going, did this couple itself with the previous complex? Non-compensatory pause. A non-compensatory pause is whenever the SA node was reset with the premature depolarization. So I'm going to go actually to the whiteboard for this. So I got a normal firing that occurred from the SA node. Bam, and there was some sort of repolarization or reentrant phenomena here that hit that thing again. Well, this is non-compensated. So it was the SA node was reset with a premature depolarization. So this depolarization wave that depolarized the atria also depolarized the SA node. So now, instead of normal R to R intervals, I'll have one that's messed up. I'll have one of them. Now, the definition in the book is an RRR, which includes a normal beat, a premature beat, and another normal beat. So out of 3 beats here, if this was depolarized, one of these beats are shorter. Now, what that will do is, I should have done it on this last one here. I'm going to erase this one. So after that non-compensatory pause, it will go back to its normal rhythm. That should be easy to spot on the EKG though. Compensatory pause. Now in a compensatory pause, we still are talking about an RRR sequence that contains a normal beat, a premature beat, and another normal beat. But the SA node did not get reset and will now start over in its rhythm area. So whenever we get a compensatory pause, whenever that beat occurs, boom, it is going to compensate for the time frame. Again, SA node, AV node. These are just going to look like funny looking beats, so they're going to be irregular. We're going to spot them by their irregularity. And then after we spot them by their irregularity, we need to identify them so we'll know which pacemaker site they're coming from. Very simply. So the compensatory pause, the SA node did not get reset. So it fired, it has its own rhythm, and then all of a sudden we had an aberrant beat. But the SA node did not get reset on this, so then it fires its normal rhythm. So this will look like the aberrant beat, but still we get these intervals are supposed to be the same, even though I'm not exactly drawing them the same. So both of these intervals here between this beat here and this beat here would be the same as this area here. The funny looking beat would just be an addition. Let's clear this off. Bigeminy, which means every other beat. Trigeminy, which means every third beat. Quadrigeminy, which means every fourth beat. Multifocal, very simply, means it's coming from different focal points. And unifocal means it is coming from one. One, many, every fourth, every third, every other. Standardized rhythm descriptions, important concepts. Premature atrial complexes. A PAC is a premature atrial complex. It looks like another sinus-originated beat. The only thing with a PAC, though, go back to basic EKG on this, if you need to, is that the atria, the P wave of the PAC is going to look different than the normal rhythm. That's because it comes from another spot. A premature junctional complex, very simply, is a junctional complex, no P wave or inverted P wave, that originates prematurely. And that would mean without a P wave. Ventricular premature beat, forms of ventricular premature complexes, they can be unifocal PVCs, they can be multifocal PVCs, or they can run in salvos. Lowndes criteria, which we're going to look at on the next sheet, is a threat assessment of how these PVCs, or what our thought process by looking at these PVCs are doing to the patient. So do we need to correct them or not? And that's what this criteria is here on the next page. And I'm going to clear this off so we can talk about it. Low risk, so they have no PVCs or they rarely occur. This would be less than 30 of them an hour. So immediate risk would be frequent PVCs greater than 30 per hour. And a high risk, and this is the area probably that we need to look at treatment, they're coming multifocal. They're coming from different sites. So all the PVCs look a little different. They're repetitive. They come in couplets, which means they come in twos at least. And they come in salvos. And a salvo can be up to a run of VTAC. So you could have multiple. Or they're on T phenomena. They're getting really close to our T wave. Now, from basic EKG, if you'll remember, our T phenomena, very simply, can start over a pacemaker site of its own. So if that's in the ventricles, Very simply, it can become VTAC or VFib very easily. Decreased automaticity, and this would mean decreased amount of electrical availability or decreased amount of signaling initially. Causes on this are they can be caused from ischemia. This would decrease the amount of automaticity that's present. A sinus pause or arrest. Stokes-Adams attack. Now, Stokes-Adams attacks are the sudden loss of consciousness without warning while sitting or standing. They're like a type of syncopal episode. Generally, though, in Stokes-Adams, the EKG will show a systole, AV block, VFib during these attacks. So these patients need to be helped out if they're having Stokes-Adams attacks. And then sinus bradycardia, which would just be a slow sinus rhythm. History. History should always be important here. Considerations. Was the patient weak or dizzy whenever this occurred? History of OPQRST mnemonic. Focus on hemodynamic effects of the dysrhythmia. Did they have any prior history to this? Past medical history as far as sample mnemonic. Signs and symptoms. Allergies, medication, past medical history, last meal. Medication record, if they're on any kind of medications for this, and any kind of changes in medication that might have occurred. On examination, consider your initial assessment. That would include ABCs, heart rate, blood glucose reading, cardiovascular examination, time and pulse assessments, electrocardiogram analysis. Key to clinical decision making for the patient with suspected tachydysrhythmia is the EKG, and 12-lead EKG is even better. You have 12 witnesses that essentially look at the heart in that second of time. Increased automaticity and sinus tachycardia, focal atrial tachycardia, wandering atrial pacemaker. It's all a good idea to get a 12 lead on all of these if you think that the person is in some sort of dysrhythmia. Irregular narrow complex tachycardias, and this would be AFib and aflutter. Atrial fibrillation with rapid ventricular response, Ashman's phenomena, short bursts of abnormally conducted supraventricular impulses is what Ashman's phenomena is. Chronic persistent AFib, multiple impulses, complete multiple circles within the atria, and these impulses kind of bombard the AV node, and accelerated junctional rhythms. Junctional tissue initiates an impulse rate that is greater than 40 to 60 beats per minute. Junctional ectopic tachycardia can result from this as well, if it's over 100 beats per minute. Ventricular rhythms. This is a differential look at AFib versus ventricular rhythms. So we should always take a look at our axis, and this comes from 12 leads. So anybody that's giving us an ERAD axis or has concordance of the V leads, please really look at their heart rhythm to be sure that we're not in VTAC. But if it's an atrial rhythm and it's irregular, especially in AFib, it will not have a regularity to it. It'll be irregularly irregular. There won't be a specific rate. That will be variable too, and that depends on which one of the F waves that the AV node picks up. The shape of the P wave, none is going to be fine fibrillatory waves. The PR interval, none, and AV relationship, none. Narrow QRS with an irregular rhythm. The irregular rhythm suggests multiple foci in the for tachycardia cases. Important concepts on this are going to be accelerated idioventricular rhythms, which would be above 40 beats per minute, all the way up to 100. And now at the point that it's at 100 beats per minute, then it would be considered really a ventricular tachycardia, but we generally don't treat VTAC unless it's above 150. Premature atrial complexes, which would be extra atrial beats. Premature junctional complexes, which would be premature junctional beats. And then premature ventricular complexes, which are premature ventricular beats. Wide QRS, greater than 0.12. Junctional complex, no P wave or inverted. PACs, funny looking P waves. So if you get a PAC, the PAC will be out of rhythm, 1, and 2, it will be coming from a different location. Decreased automaticity. Primary cause of this, increase in parasympathetic tone. Your body kind of works. The sympathetic parasympathetic nervous system keeps it balanced. This is fight or flight. And the parasympathetic tone, whenever this occurs, we get a sympathetic dominance, kind of depresses. Now, if we get a reversal of this, I'm going to erase these. If we get a reversal of this to where we have an increased parasympathetic tone, this is feed or breed. It also slows down our heart rate if we get an increased parasympathetic tone. So this is going to leave a sympathetic depression in the body and slow down the heart rate. Assessment. Supraventricular tachycardias are going to have a short PR interval. Refractory period begins at the QRS complex to the end of the T wave. Time represents time of repolarization. Shorter in errors of conduction, and it's longer in errors of automaticity. And let's review the refractory periods here for just a second. So we have a QRST, and I'm going to change colors here for a second. So from the start there till halfway through the T wave is the absolute refractory period. This spot here, halfway through the T wave to the end of it, is the relative refractory period. Now, what this means for us, in the absolute refractory period, the stimulus is already initiated, and it's all or none. So there is no other stimulus that can come into here during this time frame, during the time frame that you are engaged with the myocardial tissues. In the relative refractory period, if the stimulus was strong enough, it could take over a beat of its own. Now, this is what we worry about whenever we get an R on T. As a PVC getting really close to our T wave, we consider that a malignancy or something that we may have to adjust. Treatment. Considerations, stable or unstable. The first thing that we should look at in any kind of tachycardia or bradycardia or any rhythm is the patient stable or unstable. We determine stability off of presentation of signs and symptoms and blood pressure. So if they have chest pain, shortness of breath, diaphoresis, and their blood pressure is 130 over 70, even though that they are symptomatic, I am going to consider them stable at this point. If they cannot maintain a blood pressure or they're decompensating, their blood pressure is 80 over 40 with the same symptoms, I'm going to consider them unstable. So wide versus narrow complex tachycardia. In wide complex tachycardia, we're going to treat it with one modality, and in narrow complex tachycardia, we're going to treat it with the other. And I'm going to quickly go over these. In wide complex tachycardia, we use antidysrhythmics or medications at the point that the patient is stable. If they are unstable, we're going to synchronize cardiovert them. Same way with narrow complex tachycardia. If they are in a stable rhythm, that means blood pressure, a key assessment tool on that. If they're in a stable rhythm, we are going to give antidysrhythmics. If they are in an unstable rhythm, we're going to synchronize cardiovert them. Irregular narrow complex tachycardia. It is better to use pharmacological intervention on something like AFib. Slowly ease them into that therapeutic index, though. If we have no other way out, then we should probably initiate a synchronized cardioversion. There's always a risk whenever doing that to someone that's in atrial fibrillation. The risk is how long have they been in AFib, and could they have possibly developed a clot in the left atrium? So clotting considerations should come into play onto that as well. And risk versus benefit on treating your patient. Evaluation. Amiodarone is administered if the patient has been in ventricular fibrillation less than 48 hours. Patient is hemodynamically unstable. If ineffective or rapid decompensation occurs, we need to cardiovert this patient. So very simply on this, let's just talk about this area here that I just talked about a bit. Let's say we had a wide complex tachycardia. So it's VTAC. Let's just call it what it is. This is patient A and patient B. Patient A, they have chest pain, shortness of breath, with a blood pressure of 126/72. The question you need to ask, are they stable or unstable? And the answer is with a blood pressure like that, they are stable. Patient B, chest pain, shortness of breath, syncope, with a blood pressure of 80/40. Again, same question. We have a wide complex tachycardia. Is the patient stable or unstable? And the answer is they're unstable. Now, the patient A, we're going to use amiodarone. In patient B, we're going to sync cardiovert them. Please look at the treatment algorithms in the ACLS section for video education over the specific treatments in each one of the algorithms. Atrial fibrillation and stroke. Goal of pre-hospital care is to kind of control the rate. Do not convert the rhythm. If we convert the rhythm, it increases the chances of them throwing a clot. And if it comes out of the aorta, it's a 50-50 shot. It can either be a heart attack or a stroke that we give them. Disposition. Dysrhythmias are due to errors of automaticity. Separate class of dysrhythmia require a different treatment approach. Many will lead to catheter ablation, and this is talking about the tachycardias. I'm going to talk about this here a little bit, and the transport to a capable cardiac center. So whenever we're talking about that, an ablation, let's say that we had problems with this in the past, 2 or 3 times. SAAV. Let's say I had a second area here that like to fire itself off and hit the AV node. So the electrophysiologist could identify this area and give it an ablation, which is essentially like a controlled heart attack. They destroy that one little section, and what that does is it allows the SA node to do what it's supposed to do. In conclusion, disorders related to errors of automaticity. The patient may present with subtle complaints. Initially, it may not appear to be cardiac in nature. Can indicate a more serious underlying pathophysiology. Do a good assessment is the point of this, especially when the onset is acute or the first episode. References for this were taken from Myers, Professional Paramedic, Volume 2, Medical Emergencies, Maternal Health and Pediatrics, Del Mar Learning. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smithr@imsa.net, or 45219-7613. Thank you.